Hello students, today we will be discussing about jaw relation in complete denture. Now jaw relation in complete denture is an extremely important topic, not just for your exam point of view but also for your clinical point of view. You will be doing most of these procedures in the clinics. There will be some things which will be new, but it is an important topic to know for both practically and for theoretically. Now in jaw relations, it can be asked as a essay or it can have short notes. In short notes, they can either ask you about face bows, they can either ask you about orientation jaw relation, they can ask only about vertical jaw relation, only about horizontal, or only ascentric relation. So all these comes from the same topic. So in this class, we will be discussing the contents. We'll be giving a short introduction about what is jaw relation. We'll talk about the various types of jaw relation and we'll conclude with that. What is jaw relation? What do you mean by jaw relation? It's as simple as the word sounds to be. Jaw relations are defined as any one of the many relationships of the maxilla to the mandible. Now, jaw relation means the relation of your maxilla to the mandible. It could be any type. We are talking about this relation, or this relation. Okay, that is the three different types. I will talk about that. Now, the maxillomandibular relationship is defined as any spatial relationship of the maxilla to the mandible. Any one of the infinite relationships of the maxilla to the mandible. So, that's the GPT definition of jaw relation, or it is called as your maxillomandibular relationship. Jaw relation is kind of like a colloquial term. It is called basically as your maxillomandibular relationship. So, as the term itself suggests, it is the spatial relationship of the maxilla to the mandible. Kindly note this word as very, very important. It is a spatial relationship. You are talking as a 3D structure. You are looking at your skull as a 3D structure, and in that you are determining the relationship with keeping the skull as the base. That is why it is called as a spatial relationship. All these aspects is taken into consideration by keeping the skull as the base. Okay. What are the types of jaw relation? So first you have your orientation jaw relation. Orientation jaw relation means the spatial relationship of the maxilla in compared to the cranial base. In simple terms, your spatial relationship of the maxilla in comparison to the cranial base. So now before you compare how the maxilla is to the mandible, you have to know how the maxilla is positioned. That is why you first talk about orientation jaw relation. Orientation jaw relation will give you a determination as to how the maxilla is placed. So if you're looking from on top, if somebody is looking from on top, so this is how my maxilla is when I'm looking from the top. So you are going to see if it is straight, tilted like this, is it front or back. That sort of relationship is called as your orientation jaw relation. Then you have your vertical jaw relationship. Vertical jaw relationship as in you have your maxilla to the mandible. This height is called as your orientation jaw relation. Your vertical jaw relation. This is your vertical height or your vertical jaw relation. What is your horizontal jaw relation? Horizontal jaw relation means now your maxilla is stable. This is your mandible. Where is the mandible position? The spatial relationship of your mandible. Is it here? Is it here? So let's see if you're seeing a lateral view. If this is your maxilla, this is the mandible. Is it in front? Is it behind? Is it right? Is it left? Okay. So in horizontal jaw relation, you have two types of relation. One is your centric relation and second is your eccentric relation. What is basically your centric relation and your eccentric relation? Now, when you close, that is when you close your mouth, the position of your jaws is determined or controlled by the position of your teeth. As simple as that. You're going to close and you're going to bite on the teeth. Now that biting force, that position is determined by the teeth to teeth contact. That position is called as your maximum intercuspation position. The position at which the maximum number of tooth will contact each other. Maximum intercuspation position called as MIP, maximum intercuspation position. What happens to a situation where you don't have those teeth? How will you determine your MIP? You can't. So in such situations, if you have teeth or you don't have teeth, centric relation is always there. Centric relation is a condition inside the joint. It has got nothing to do with the teeth. Okay. In dentulous patients, in most of the situations, your centric relation will be equal to your maximum intercuspation position. If you have a proper occlusion, your centric relation will be equal to your maximum intercuspation position. Okay. Once the tooth is lost, you have to recreate that position by guiding the mandible into centric. Wow, we will discuss about centric relations. That will determine that biting position. Okay. Now that is your centric relation. What is eccentric relation? As the name suggests, eccentric. Apart from the centric, any other relation, what we are talking about, that is, you're talking about right lateral, left lateral, or a protrusive movement. You bring your mandible in the front, you take your mandible to the right, or take your mandible to the left. That is called as your eccentric position, because you're now you're taking your mandible behind and biting. That is your centric relation. Any other position other than your centric relation is called as your eccentric position. So in eccentric positions, you have two things. You have your protrusive records and you have your lateral records. Protrusive is simple, you're bringing the mandible in front. Lateral, again, you have two. You are taking to the right and left. So you have lateral, right lateral, and you have your left lateral. Okay, so this is just an overview about what are the various types of jaw relation we are going to be discussing. What is the clinical significance of establishing or recording your jaw relation? Why to do this step? To re-establish the functional position of the mandible for comfort, good aesthetics, phonetics of course, functional efficiency and structural balance. An ideal jaw relation will give you all of these. Okay, an ideal jaw relation will give you all of these. Most commonly what happens is you place the tooth in any position that you want and give it to the patient. The patient might be able to bite for sure, but if the jaw relations are not recorded properly, the patient will come back ultimately with a damaged temporomandibular joint. And remember, we always discuss about the de Van's dictum. Same applies here. You have to give something which will help maintain the structural other structures, not by destroying them. Okay. Now coming to orientation jaw relation. Now the orientation relations are those that orient the mandible to the cranium in such a way that when the mandible is kept in its most posterior unstrained position, the mandible can rotate in the sagittal plane around an imaginary transverse axis passing through or near the condyles. That's called as a hinge axis. Okay. That's a general orientation relation. Now, how do you determine the orientation relation of the maxilla? Okay. Now, you have a semi-adjustable or a fully adjustable articulator. You are going to, first thing what you have to do is, you have to take the replicate the maxilla into the articulator by the cast. So, you have the cast, that's your maxilla with you. Now, how do you place the cast on the articulator? You have to know what is the spatial relation. For that, you use something called as a face bow. This is called as your face bow. Okay. You use a face bow and record the positions and bring it and attach it to the articulator and place it here in the same relation as it is in the patient's mouth. Now, what is the face bow? It is a caliper-like instrument. Remember, this word is very important. It is a caliper-like instrument used to record the spatial relationship of the maxillary arch to some anatomic reference point or points and then transfer this relationship to an articulator. It orients the dental cast in the same relationship to the opening axis of the articulator. Now, you cannot keep the skull, okay, and you cannot ask the patient to be there every time when you are wanting to do anything regarding the into the articulator. So what you're using is, you use a face bow. It's like a caliper like instrument. You use multiple reference points from the nasion, from the earlobes, from the cranium. You take points which will stabilize the position, and then you remove it from the patient's mouth and put it into the articulator in the same position, and then you fix the position by articulating the cast. So now your maxillary cast is articulated in the same manner how it is inside the patient's mouth. Okay. So your face bow is to transfer your maxillary relationship to the articulator. You have two different types of face bows which is seen. You have a kinematic face bow and you have an arbitrary face bow. Arbitrary face bow can be either a facial type or you have an earpiece type. Now, as the name suggests, an arbitrary face bow is rather something which is like tentative, arbitrary, as the name it is. Okay. What is a kinematic face bow? Now, a kinematic face bow is initially used to accurately locate the hinge axis. So, in jaw relation, however much ever we are talking about the maxilla and mandible, we are ultimately coming back to the joint. So you must understand the importance of jaw relation is equated to the efficiency of your TMJ. So here you are going to locate the hinge axis. It is attached to a clutch in which there are tubes which is attached to the mandibular teeth. We will talk the differences about kinematic and arbitrary. We will list them out in some time. As the mandible makes the opening and closing movements, the condyle has a styli which moves in an arc. So you have an earpiece which is attached to locate the hinge axis. To this earpiece, you have a styli and a paper which is attached here. Now, the major clutch is attached to the mandibular teeth, lower teeth or the lower arch. So, as the mandible moves, as the movements are done, the joint, the styli and this joint which is placed, the condyle styli will make the patterns. Okay. Now, based on that, their position is adjusted until they exhibit a pure rotation and no translation. As we all know, when the condyles, when there is a mouth opening, okay, up to 8 millimeters, it is purely rotational movement inside the condylar axis, right? Inside the condylar fossa, it is only pure rotational till 8 millimeters. So, as you open for 8 millimeters of your mandible, it's purely rotational movement. When you open further ahead beyond 8 millimeters is when your condyles will start translating movements. That is your translation movements. That is, it hits at the articular eminence and slides down and your mouth opens. So that is your mandibular movement. So here we are recording that pattern till you get pure rotation and no translation. Okay. Now the points of rotation are marked on the skin and this determines the true hinge axis. Okay. The styli will record and you get that point of the true hinge axis. The mandibular clutch is removed and the face was attached to the maxillary arch. The true rotation points are again used to orient the tips of the styli. Okay. So that is how a kinematic face bow will work. First, it is attached to the mandible, then it is attached to the maxilla. Okay. And the major function is to record the hinge axis. Coming to the arbitrary face bow. So this is how an arbitrary face bow will look like. It will have a condylar rod. Okay. It will have a U-shaped fork which goes inside the, which is having a frame. It has a bite fork on which the teeth is Either you bite on the teeth or you place it into the maxillary arch. You have a locking device which locks the whole system, and you have a styli which stabilizes you have a nasal styli which stabilizes the face. Now, the arbitrary type of face bow is so called because it uses arbitrary located marks on the skin at the condyle points as the hinge axis position. First type is a facial type. In the facial type, the condyle rods are positioned in a line extending from the outer canthus of the eye to the superior inferior center of the tragus. So, you have this line from the outer canthus of the eye till a point at the tragus. Okay, and approximately 13 millimeter anterior to the distal edge of the tragus of the ear. This locates the condylar rods within 5 millimeters of the true center of the opening axis of the jaws. What is the earpiece type? Earpiece type is you are placing it inside the condyle point. It's placed inside the earpiece. The earpiece face bow is designed to fit into the external auditory meatus. Here also the focus attached to the maxillary rib. So in arbitrary, mostly the focus always attached to the maxillary. And in this, again, you will be taking the records and it is transferred into the articulator. Coming to vertical jaw relation, the amount of separation between the maxilla and mandible, okay, according to GPT-8, it is the distance between two selected points, one on a fixed and one on the movable member. That is, one fixed point is on the maxilla and one fixed point is on the mandible. That is, one is a fixed member, one is the movable member. The vertical dimension of the face between any two arbitrary selected points located one above and one below the mouth, usually in the midline, along the midline. That is important for your vertical jaw relation. Vertical jaw relation, there are three types. One is vertical dimension at occlusion, vertical dimension at rest, and vertical dimension in other positions. What is vertical dimension at rest, or simply we call it as VDO? The distance between 2 points when the occluding members are in contact. At occlusion means when in occlusion. At contact, so it is vertical dimension occlusion. It is a relation of the maxilla to the mandible when the occlusal stops are provided by the teeth or the occlusal ribs. What is vertical dimension at rest? The distance between two selected points measured when the mandible is in a physiological rest position. Okay, it is in a physiological rest position. It is not in occlusion. At that position, what is the height between the maxilla and the mandible? Coming to interocclusal distance or the interocclusal rest space. Now, the difference between the resting vertical dimension and vertical dimension of occlusion, it was first studied by Niswonger. So, that is why it is called as Niswonger space. Ideally, it should be around 2 to 4 millimeters. What is verticentric? It involves the simultaneous recording of vertical dimension of the occlusion with the jaws in centric relation. Vertical dimension of speech is the distance measured between the two selected points, occluding members, in closest proximity during speech. So, this is the difference between the vertical dimension at occlusion and vertical dimension at rest. So, always VDR will be more than the VDO at occlusion, right? So, this difference between VDR and VDO is called as your freeway space, which is usually around 2 to 4 millimeters. Okay, and it is called as Niswonger. By recording, it is called as Niswonger's method. Now, coming to the common factors to consider while recording vertical jaw relation is the position of the mandible is influenced by gravity. Therefore, you can't have the patient reclining back or tilting in front. The patient should be calm, cool and relaxed and with the mandible parallel to the floor. It is difficult to record in patients with severe neuromuscular disturbances. And you have various techniques for recording the same. You don't have a single one-shot technique. You can record it in various methods. Methods of recording vertical jaw relation are: first is the mechanical methods. In this, the ridge relationship is recorded, that is distance between the incisive papilla to the mandibular incisors. Second is by checking the parallelism of the ridges. Next method is measurement of the former dentures. If you have had an earlier denture and you want to do a new one, you can always take. But this can always show a lot of disadvantages for this method. Why? Because in case of a patient who has been using a denture for a very long period of time, let's say for 10 to 12 years, there is definitely going to be a lot of attrition. So definitely the vertical dimension would have reduced. Okay. Now, then you have pre-extraction records like profile photographs, you have profile radiographs, casts of the teeth with occlusion, and facial measurements. That is your mechanical methods. Then you have your physiological methods. In physiological methods, you have your physiological rest position, phonetics and aesthetics as a guide, swallowing threshold, and tactile sensations. Now, methods for recording in the physiological methods. The first method will be Niswanger's method, given in 1934. Now, like we know, you have the interocclusal distance, which is 2 to 4 millimeters at the first premolar region. That is very important. Not in the anterior, not in the posterior. It is in the first premolar region. You make two marking. One is at the base of the nose and one is at the chin. So, base of the nose and the chin. Disadvantages: now because you are marking on the skin, it can always wear off, and it is not like it is a permanent reference point. Coming to the effect of increased vertical dimension, there is increased risk of trauma because there you will have clenching of teeth. It will be discomfortable to the patient. Teeth are liable to contact. That is, if you increase your VDO, what will happen? You are keeping at a higher level than your required level. So every time the patient tries to talk, there is no space between the teeth. It starts hitting the teeth. So it will cause clicking during speech. That is a classic sign to know that your VDO, vertical dimension at rest and occlusion, is wrong. Now, once that happens, when the patient bites also, it is not in a relaxed position, which can definitely cause clicking and pain in the TMJ. Trauma and pain, because excess every single time you talk, there is pressure on the dentures and it will cause trauma to the denture bearing area. Loss of freeway space will cause muscular fatigue. An effect of the increased vertical dimension continues. Clicking sound from the joint. Again, elongated appearance of the face. Bone resorption is more. Loss of retention and stability of the dentures and generalized hyperemia is seen. Straight opposite, what happens when you have a reduced vertical dimension? Okay, there is reduced masticatory efficiency, poor aesthetics, cheek biting, tongue biting, lip biting, because the lip will get entrapped in between. It will look like you have placed a denture. You can have angular cheilitis, pain in the TMJ, you have Costin syndrome, and prognathism is evidently shown. Now, tests to aid in confirming the correct vertical dimension: judgment of facial support, visual observation of the space between the rims, and observation using sibilant words. Next, we will discuss about the horizontal jaw relation. So, we have completed orientation jaw relation and your vertical jaw relation. We will next discuss about your horizontal jaw relation. Horizontal jaw relation, we already discussed. You have centric relation and eccentric relation. And in eccentric relation, you have your protrusive records and your lateral records. What is centric relation? Please make sure to thoroughly study this definition. It's very, very important. A very common Viva question also. Centric relation is defined as the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs with the complex in the anterosuperior position against the shape of the articular eminence. This position is independent of tooth contact, and is discernible when the mandibular is directed superiorly and anteriorly and restricted to purely rotary movement about a transverse horizontal axis. So this is what centric relation means. So it is the maxillomandibular relationship with the condyles. It is placed in the thinnest avascular position of their respective discs. Okay. Now this whole complex of the condyle and the disc, okay, all this is, where is the position? It is positioned in an antero-superior position against the shape of the articular eminence, against the slope or the shapes of the articular eminence. That is the centric relation position. This position is completely independent of tooth position, and it is discernible when the mandible is directed anteriorly and superiorly. And in this position, you have only purely rotational movement, no translation. Okay. This whole thing is the definition of centric relation. You can't stop it with this. Okay. You have to mention the whole thing. According to GPT-8, this is the most accepted definition of centric relation. Now, methods of recording centric relation. You have the functional methods or the Chewin methods. You have needle house method, Patterson methods, and Mayer's method. Then you have the excursive methods, or it is called as a graphic methods, in which you have the intraoral tracing or an extraoral tracing. You have something called as Gothic arch tracers, which is attached to the occlusal rims, and then you record the intraoral and the extraoral tracings. And then you have tactile or interocclusal check records and terminal hinge axis method. Other methods are heating the surface of one of the rims, softening the wax placed on the occlusal rims, and then softened cones of wax is placed and the lower denture trial bases are done. Coming to functional methods, first is the needle house method. It's the most commonly used. Occlusal rims are fabricated with impression compound. 4 metal beads are embedded in the maxillary, premolar and molar regions of the occlusal rims. They are inserted into the patient's mouth and close the occlusal rim and make protrusive, retrusive right and left lateral position. Now, when this beads, with the beads inserted and this position is done, you get diamond shaped marking on the mandibular occlusal rims. The tracing incorporates the movement of in the 3 planes, and records are placed in the suitable articulator to receive the duplication of the record. So you have like 4 beads or styli which is placed, and you make the patient move and you get this kind of a diamond marking. In this diamond marking, the farthest behind will be the centric relation position, and farthest in front will be the maximum protrusive. Then you have the maximum right lateral and the maximum left lateral. This is what's called as needle house technique. Coming to the Patterson's method, wax occlusal rims are used. A trench is made in the mandibular ridge. Okay, so trench is basically like a trough. And a mixture of half plaster and half carborundum paste should be used in the trench. Now, the mandibular movements generate compensating curves in the plaster and the carborundum paste. When the paste is reduced to the predetermined vertical height of occlusion, the patient is instructed to retrude the mandible and the occlusal rims are joined together with metal staples. So basically you have this trench which is made along the whole mandibular denture, and you pour a mixture of plaster and carborundum or maybe plaster and pumice mixture into it, and you make the patient do all the movements, front, back, right, left, front, back, right, keep repeating it. So what happens is the compensating curve is included and the mediolateral curve is also generated. Coming to the Mayer's method, in Mayer's method you use soft wax on the occlusal rims to establish a generated path. Tin foil was placed over the wax and lubricated. The patient performed the functional movements to produce a wax path. The plaster index was made of the wax path and the teeth were set to the plaster index. Coming to recording the excursive movements. The most common of the excursive movements recording is done by using Gothic arch tracing. Now, this can be employed two ways, either intraorally or extraorally. So, you have, now when the recording comes, it comes like an arrow, a sharp pointed arrow. Okay. Now, it is also called as an arrow point tracing. Now, earlier during the Gothic arch period, this kind of shapes were called as Gothic arches. So, that's why it's called as a Gothic arch tracing. So, in an intraoral Gothic arch tracing, you have a central bearing device which is attached to your, and you have it is like a plate. It comes like this, okay. So, you have two plates like this which is coming. One will be a plate and one will have a styli in the center. Alright. So, you have a central bearing point, this, and a central bearing plate. Now, the central bearing point is attached to the maxillary rim and the plate is attached to the mandibular rim. Both are is placed inside the patient's mouth, and the patient is asked to do all the centric, and once the centriculation is done, you are asking the patients to move in the maximum protrusive, right lateral and left lateral. Okay. Now, so intraorally also this arrow is going to be formed. Major disadvantage is that it is going to be a very thin tracing. Okay, a small thin tracing. So, mostly what you do is you paint the plate with some material like maybe thinned out plaster or some very loose paint so that this marking can be seen. Coming to extraoral what you have is you have a central bearing point in the maxilla and one in the mandible. So, you are attaching it like a fork to the maxillary occlusal rim on the buccal aspects, and you have a long styli which comes, and then you have the pointer and the plate. Now, you can, when the patient does the movements, you can stand extraorally and view the marking on the extraoral plate. Easy identification. Now, unless there is a sharp pointed arrow, you cannot accept the tracing. A blunt apex will indicate an acquired functional relationship and a sharp apex indicates the position of the centric relationship. So, in this arrow, this is your centric relation and this is the right lateral and left lateral. Okay. Double tracing, if it is available, coming, it indicates lack of coordinated movements. So, what you usually do is you ask the patient to again, you train the patient multiple times and then go for your tracing again. This is how an extraoral tracer and an intraoral tracer will look like. Coming to the interocclusal check records, it is particularly indicated in situation of abnormally related jaws, excessively displaceable supporting tissues, large awkward tongue, uncontrollable or abnormal mandibular movements to check the occlusion of the teeth in trial dentures. Next method will be to do the nick and notch to index the occlusal rim. Up to 3 mm of wax is removed on either side of the mandibular rim. 1 or 2 notches are cut in the maxillary rims. V-shaped valleys like notches are made in the maxillary, totally across the width of the maximum occlusal rim. So, one nick is cut in the anterior to the notch. That is, nick prevents the lateral movements and notch prevents the anteroposterior movements. So, so in this case, what you're going to do is you're going to mix zinc oxide eugenol or something. You're going to, or plaster. You're going to place it into this nick and notch so that it doesn't break off or you don't lose the relationship. It's done. It is placed into this nick and notch and ask the patient to bite in centric relation and wait till this material sets. Now, the zinc oxide eugenol which is projecting will help in reorienting this maxilla and the mandibular occlusal rim onto your articulator. So, remember on the articulator you already have your face bow transfer maxilla. Now, the mandibular relationship comes from this nick and notch method that you have taken after the tracing, and you are going to articulate the mandibular also. So, this is how basically a nick and notch will look like. Can you see this is the nick here, all right, here, and you have a notch next to it. So, that is how the jaw relation, horizontal jaw relation record, interocclusal record is made to transfer it into the articulator. A word about the terminal hinge axis. As in the determination of this physiological transverse hinge axis, the mandible is in its most posterior relation to the maxilla when the centric relation is recorded. Therefore, if the upper cast is correctly oriented to the hinge axis of the articulator by an accurate face bore transfer, the lower cast will also be correctly oriented to the opening axis of the instruments when it is transferred to articulate with the accurate centric relation record. Coming to eccentric jaw relation, you have protrusive records. Eccentric records can be protrusive and lateral. Now, the graphic method of making mandibular static records is performed in the same sitting position after the mandibular cast has been mounted in eccentric relation. The recording device is replaced in the patient's mouth. A distance of 5 to 6 mm is measured from the apex of the arrow point tracing and the protrusive tracing is marked. The patient is instructed to protrude until the point of the stylet rests on the mark. It cannot go further beyond the 5 to 6 millimeters because you cannot push your mandible further beyond 6 millimeters. Now, a quick setting dental stone is injected to seal the rims. That is, once the patient moves from centric to a protrusive, automatically there is a space which comes between the occlusal rims. So, you inject something, a fast setting material into that space and ask the patient to hold it in that correct protrusive position so that that record sets. Then you slowly ask the patient to open the mouth and take out that protrusive record, and you can maybe write it as P and mark it. So that is your protrusive record. In the similar way, your right lateral and your left lateral records can also be taken from the same tracing, because when you're moving it to the right or to the left, the same way the material is injected and it is held in place and the records are made. Now, you can also get so now this is your lateral condylar inclinations and your horizontal condylar inclination. The formula to determine while programming your articulator is given by Hanau. So, this is the Hanau's formula which shows L is equal to H by 8 plus 12, where L is your lateral condylar guidance and your H is your horizontal condylar inclination degrees as established by the protrusive relation records. So, with this we are concluding our jaw relations. We have discussed all the three types of jaw relation, what all will be used. Articulators will be taken as a separate topic completely. Establishing the jaw relation is an important step in the fabrication of complete dentures. Orienting the upper and the lower denture in the correct horizontal and vertical relation to one another is important for the aesthetics, health and comfort of the patient as well as proper functioning of the dentures. In final analysis, it is the experience and judgment of the operator and to some extent the patient himself which helps in determining what is right for the patient. Thank you.